Today will be the last polling session for this webinar series. So now I request Dr. Amrish to actually introduce our moderator of the day, Dr. Sharon, to you.
Thank you so much, Dr. Kalavani. Welcome, everybody. And I know this is a very international audience here. And good morning, good afternoon, good evening. And I'm so happy to introduce our moderator for the session, Dr. Sharon Tao. She's a pediatric nephrologist and consultant in the Division of Pediatric Nephrology at the National University Hospital in Singapore. She did her MBBS and her postgraduate training from Australia, and she has been very active in the Australian groups. Her special interest includes in pediatric dialysis and chronic kidney disease and kidney transplantation as well. She has published numerous articles, including lot on nephrotic syndrome, kidney transplantation. Welcome, Dr. Sharon, and I would hand over the mic to you.
Thank you, Dr. Amrish. Thank you, Dr. Kalavani, both of you for inviting me to join your Webmaster series. I've been attending this for the past 5 years as well, and very interested and excited to be here today. And so good morning and good evening to everyone, and a warm welcome to today's webinar. I'm very honored to be moderating today's session, and we have two very exciting talks lined up today. So for our first talk, it will be on ambulatory blood pressure monitoring, and I'm very pleased to introduce our speaker for tonight, Professor Joseph Flynn. Dr. Flynn is a professor of pediatrics from Seattle Children's Hospital. He holds the Dr. Robert O. Hickman's Endowed Chair in Pediatric Nephrology. His academic interest is in childhood hypertension and cardiovascular disease in children with CKD, and has published multiple guidelines in this area. And I'm sure most of you have known of him and all his guidelines. His awards is a true testament of his contribution in the field of pediatric nephrology, having been the recipient of the Barnett Award in 2019 and the Founders Award in 2020. So without much further ado, Dr. Flynn, I'll hand over this time to you to share with us about ambulatory blood pressure monitoring.
Well, thank you for that introduction. Nice to be here. And I was asked to talk about ambulatory blood pressure monitoring, something I know a little bit about. So I wasn't asked what exact topic to talk about, so you're going to have to hopefully enjoy the selection that I've made. Let me get my slides up for you. All right, so as I mentioned, there's ambulatory blood pressure monitoring is a big topic, so I narrowed it down a little bit to talk about how we use it to diagnose hypertension, and then also identify various cardiovascular risk factors. So our talk today will briefly talk about ambulatory blood pressure monitoring, then go on to review its use for confirmation of the diagnosis of hypertension, and then to talk about how ABPM can be used to identify cardiovascular risk factors. So, as you know, there are many factors that can affect manual blood pressure measurements, including things like body position or even arm position, activity level, emotional state. There can be, those are the patient-related factors, and then the provider-related factors include, making sure you've chosen the right size cuff, and then people have what's called terminal digit preference, and can have observer bias. I want the blood pressure to be lower. So the sort of solution to overcome those problems is to do ambulatory blood pressure monitoring. a process in which patient wears a lightweight blood pressure monitor, which takes blood pressure at regular intervals over 24 hours, usually every 20 minutes during the day, every half hour overnight. This will allow assessment of blood pressure outside of the office and during the patient's usual activities. There are specific blood pressure phenotypes which we come up with or categorize using ABPM, as I will talk about. And then it's been endorsed by various consensus organizations for confirmation of the diagnosis of hypertension in children and adolescents. And then it predicts target organ effects of hypertension, which we will talk about later. And then in adults, it correlates with cardiovascular outcomes that we will not talk about since there are no available pediatric data. So there are many different ambulatory blood pressure monitor models on the market. Some of them are pictured there. They're relatively small. I think they're quiet. Some of my patients argue with me on that point. As I said, they take many measurements over 24 hours. At our center, if someone is completely perfect for their ambulatory monitoring study, we get about 62 readings over 24 hours. And then, as we said, it captures blood pressure in the patient's normal activities at home, at school, in the case of our patients. It also allows us to evaluate blood pressure during sleep, which, as we'll see, can be very important. So the benefits of ambulatory monitoring are listed there. As I said, there are no problems such as digit preference or observer bias. It allows us to identify specific patterns of blood pressure, which we will talk about. It allows us to perhaps identify children who are more likely to have secondary causes of hypertension. And it's been shown to be cost effective in terms of the workup of children with suspected hypertension. In the 2017 American Academy of Pediatrics Clinical Practice Guideline, we endorsed ambulatory blood pressure monitoring in several settings. First, to confirm the diagnosis of hypertension after 3 high office blood pressure readings, to help differentiate between those patients who have just white coat hypertension as opposed to sustained hypertension. It lets us identify blood pressure patterns in high-risk conditions like chronic kidney disease and diabetes. And then the other endorsed use is to assess adequacy of blood pressure treatment, which in chronic kidney disease, we look for the mean arterial blood pressure to be below the 50th percentile. And then after starting therapy in other patients, repeat ABPM can be used to assess how well the hypertension is being controlled. Ambulatory monitoring is interpreted by looking at the average blood pressure for each time period and comparing it to normative data. This is our most recent recommendations for classifying ambulatory blood pressure monitoring in children. And so you'll see that you would compare the mean blood pressure to either the 95th percentile for height and gender or adolescent cut points, which are listed there on the right-hand side, depending upon how tall the child is and their age, and based upon the office blood pressure and the ambulatory blood pressure, then decide which blood pressure pattern they were following. And that is, again, just shared here in this more simple representation where, for example, white coat hypertension is where the office blood pressure is high, but the ambulatory blood pressure is normal, as opposed to patients who have ambulatory hypertension where both are elevated. So just a couple of words about white coat hypertension, because this comes up a lot. This is defined as blood pressure above the 95th percentile in a physician's office in a patient who is otherwise normotensive. The pathophysiology is a little unclear. It's not well studied. It's felt to be perhaps a transient stress response, and perhaps that it may also reflect anxiety on the patient's part. It's very common in children. In some papers, it accounts for up to 40 to 50% of children referred for elevated office blood pressure. But one thing we know is that the higher the office blood pressure is, the less likely the patient would be to have white coat hypertension. And this is illustrated on this ambulatory monitoring tracing, where patient was in the office here, their blood pressure was elevated, they left the office, and it was normal the whole rest of the time, normal overnight, and a few high ones during the second day, but overall normal blood pressure over the 24 hours. That's compared to this patient who had high office blood pressure, and then when their ambulatory study was done, they were very frequently above the cut point during the day, both the first day and the second day, and then mostly normal overnight. This would be categorized as ambulatory hypertension. And then what about masked hypertension? This is a little bit of a different concept. We say that a patient has masked hypertension when their office blood pressure is normal, but if they get ambulatory monitoring done for some reason, their ambulatory blood pressure is abnormal. This is frequently seen in patients with diabetes, kidney transplant, repaired aortic coarctation. In adults, masked hypertension is associated with increased risk of cardiovascular events such as heart attacks and strokes, and actually is also predictive of mortality. In pediatric chronic kidney disease, we know that masked hypertension can be suggestive of target organ damage, and detection of masked hypertension in these high-risk conditions is one of the primary rationales for performing ambulatory monitoring. Here's a patient of mine who turned out to have masked hypertension. This was a little boy who had had a kidney transplant and had relatively normal office blood pressure. But then when we did his ambulatory study, his wake blood pressure was quite high. His sleep blood pressure was quite high. The normals would be for his age 120/80 and 110/65. forget about the load here, and he had blunted systolic blood pressure dipping. And so this patient has abnormal ambulatory monitoring despite office blood pressure being normal, and has masked hypertension. In the chronic kidney disease in children study many years ago, we looked at those children who had echocardiogram data, ambulatory blood pressure monitoring data available, and to determine the prevalence of left ventricular hypertrophy. About 20% had LVH, 38% had masked hypertension, and 20% had office hypertension, and left ventricular hypertrophy was just as common in those with masked hypertension as those with confirmed hypertension, as you can see over here on the right. Now I'd like to discuss some data from a study we've recently completed in the US called SHIP-AHOY, which is illustrative of the use of ambulatory blood pressure monitoring to assess cardiovascular risk. SHIP-AHOY was a cohort study conducted at 6 North American centers in which we recruited 400 adolescents between 11 and 19 years of age with normal and slightly elevated blood pressure. And we performed various target organ assessments amongst the cohort, and it allows us to understand how ABPM can be useful in identifying children with cardiovascular risk. One question that we decided to answer with SHIP-AHOY is, when should ambulatory blood pressure monitoring be performed in patients who present for evaluation in the office? And this paper was published quite a while ago now, led by our fellow at the time, Gilad Hamdani. We know that the AAP clinical practice guideline recommends ambulatory monitoring for confirmation of the diagnosis of hypertension after 3 blood pressure readings in the elevated or stage 1 hypertensive range, and after 2 blood pressures that are at the stage 2 hypertension level. However, ambulatory monitoring may not be widely available, and you may need to pick and choose which patient undergoes ambulatory monitoring. So the research question here was whether we could, by looking at our SHIP-AHOY data, identify an office blood pressure level that was associated with ambulatory hypertension and would be a blood pressure level at which ambulatory monitoring should be done. So this was data on the first 250 SHIP-AHOY participants. We looked at various clinic blood pressure percentiles and cut points to determine which of those was ideal for predicting ambulatory hypertension. We found that the prevalence of ambulatory hypertension increased as office blood pressure increased. That is not surprising, and that's similar to what I had already mentioned. But the other thing that we found was that actually the 85th percentile for office blood pressure had very good sensitivity and specificity, 86% and 57% respectively, compared to elevated blood pressure, which is at or above the 90th percentile, which is to diagnose ambulatory hypertension. And so this was our graph of how often patients were hypertensive, what their blood pressures were. So you can see that here, the percentage with wake or sleep hypertension according to various cup points is listed there. And then when we look at sensitivity and specificity, the 85th percentile of office blood pressure had excellent sensitivity and reasonable specificity for predicting ambulatory hypertension on the ambulatory blood pressure study. The cut points, we also at that point, that was a transition period towards the new guideline, and we looked at prediction of the cut points from the clinical practice guideline compared to those from the older guidance in the fourth report, and the CPG cut points performed very well. We've noted that adolescents with office blood pressure at or above the 85th percentile should undergo ambulatory monitoring. And then what's interesting is that we had a very high rate of white coat hypertension in that group of children, 60%. And so if you put all this together, it allows us to optimize use of ambulatory monitoring when it's not widely available. The next question, and this gets into the question of identifying cardiovascular risk, is what ambulatory blood pressure level predicts target organ changes such as left ventricular hypertrophy. And so this was a study in which we compared adult and pediatric ambulatory blood pressure analysis criteria, both mean blood pressure and blood pressure load as predictors of left ventricular hypertrophy. And we calculated, again, sensitivity and specificity of various cut points. This was a more complete cohort, so their mean age was around 16. There were more males than females, so it was mostly a Caucasian population. It was a heavy group. Their mean BMI percentile was 92.4, which is pretty high, and actually over 60% could be categorized as either overweight or obese. 20% had left ventricular hypertrophy, which is very interesting because that's very similar to what we saw in the chronic kidney disease population. And what we found were that adult ABP cut points, specifically those from the American College of Cardiology, American Heart Association guideline, identified more participants as hypertensive than use of the German normative data, which actually is not surprising since the German normative data at some in older adolescents actually exceeds adult criteria, which is one of the problems with those data. And so this was the determination of hypertension based on different cut points. So just showing you that comparing the 95th percentile of wake blood pressure to the adult cut points, there were more participants with hypertension using the adult cut point. And this was also true overnight, where 45% were found to have sleep hypertension using the adult cut points compared to only 17% using the 95th percentile. When we looked at the sensitivity and specificity for prediction of LVH, again, we found that 130 systolic had the best balance of sensitivity and specificity for prediction of left ventricular hypertrophy. So we also looked at load because it was in univariate analysis associated with left ventricular hypertrophy. When we looked at area under the curve using receiver operating curve analysis, we found a somewhat higher AUC when for mean blood pressure than for load, but it wasn't very different. But in the multivariable analysis, only mean systolic blood pressure was associated with LVH. When load was added into the model, it did not improve the area under the curve. And this is one of the studies that informed the 2022 AHA Pediatric ABPM statement, in which we dropped blood pressure load from the criteria. With that, I'll stop and hope that I've given you a taste of what ambulatory blood pressure monitoring can do in terms of helping you to diagnose or confirm hypertension in your patients, and also in looking at various markers of cardiovascular risk, such as left ventricular hypertrophy.
Thank you so much, Dr. Flynn, for that very insightful talk. It was definitely very useful. We have some time for some questions for Dr. Flynn, so feel free to put that in the question and answer box. So Dr. Flynn, someone in the chat has asked, are there any data for ABPM used in children less than 5 years of age?
Well, let me get out of sharing. Should I get out of sharing mode?
Yes, still sharing.
Yeah. Oh, here. There we go. So I think that there are limited data in younger children. Actually, there was a paper in which they did ambulatory blood pressure monitoring in 18-month-olds or children as young as 18 months. I think they had to ACE wrap the child's arm to their thorax to be able to get them to tolerate wearing the device, which is why we generally don't. The major issue is that there are very few, if you look at the German data, they didn't have very many children who were that young, and really none who were less than 120 centimeters. And so for that reason, a lot of people won't do it until the children get to be a little bit older. And at our center, except for the CKD population, in which we will do it in younger children, we generally wait until the kids are around 8 or 10, because they just tolerate wearing the device better.
Okay. And speaking about CKD children, we know that our CKD children are all a little bit short and severely stunted. The ABPM thresholds to be taken, is it based on age or observed height?
Yeah, I would think height is best.
Okay. And one participant asked, how much should be the nocturnal dip in an ABPM?
Right. So normal, so the dip, for those unfamiliar with the term, is the decrease in blood pressure at night compared to day. And generally we say the ABPM, the dip should be 10% or more, and that less than 10% is considered abnormal.
Okay. Dr. Flynn, in your experience, I know a lot of, well, my kids anyway, when they do ABPM, they say that the machine wakes them up at night and they wake up in the night and their blood pressure goes up. So instead of having a dip, it goes up instead. What do you think of that in your experience?
Well, there's 2 points. So yeah, in fact, one of our little papers from Shipahoy, we looked at tolerability of ABPM and how it affects the results. And we found that those who didn't tolerate wearing the device very well had abnormal ABPM studies more frequently. I mean, the blood pressure really should not, but the second part of your question, the blood pressure should not be higher overnight than during the day. So, in the monitor that we use, you can tell the patient's activity level, and I can tell when they fell asleep. And if their blood pressure, is increasing overnight, then that's really quite abnormal, and that is probably a patient who you should worry about.
Okay. When is the appropriate time we measure the ABPM in twice a week hemodialysis patient? Is it after HD session or before HD session?
Oh, that's interesting. The standard for hemodialysis is 44-hour ambulatory monitoring, and that's based on 3 times a week hemodialysis, where you would place the monitor after the completion of a dialysis session, and the patient wears it until they come back to dialysis 2 days later. I have no idea with, well, I guess if you're doing twice a week, you're going to have 3 to 4 days in between sessions. And I guess what I would recommend would be starting the monitor after completion of dialysis and then having the patient come back 2 days later to have the monitor removed, or telling the family to take it off after 48 hours.
Okay. So if a patient with CKD is already on antihypertensive medication and they demonstrate inadequate dipping, we would identify them as high risk of cardiovascular morbidity. Does it require a prescription modification for that?
Yeah, and then there you also, for the CKD patients, what you should be looking at is the 24-hour mean arterial pressure. And based on the data from the ESCAPE study, the goal is to have the 24-hour mean arterial pressure below the 50th percentile. And often, if the blood pressure is not there, often they're going to have hypertension during the day too. And so the answer then becomes, yes, you need to give them more medication.
And what are your thoughts on looking at the BP load, and what happens if there's cases where there's a normal mean blood pressure but a high BP load for these patients?
So we don't look at load any longer since the 2022 AHA guideline. We feel that it is it's not useful in improving prediction of cardiovascular risk. We showed that in Shipahoy, and we showed that in the chronic kidney disease in children study as well. So that patient, well, I wouldn't even, now when I'm analyzing my patient's ABPMs, I don't even look at the load.
Okay.
So that is, we used to worry about those patients, and now we say, well, if their mean blood pressure is normal, we don't care about the load.
Great, excellent. Okay, just back to young children, the ones that maybe ABPM is a little bit more difficult. Would you recommend maintaining a good home blood pressure monitoring instead, but in the young ones, or?
Yeah, I mean, that's what we'll do when I have a, excuse me, if someone sends me, a 4-year-old with high office blood pressure, we'll give them, we have a validated home device that our hospital lets us give to patients. And our nurses will teach the parents how to take blood pressures, and we'll have them do home blood pressures.
Okay. Well, thank you so much, Dr. Flynn, for your time. We were very grateful for what you have shared with us today. Feel free to hang around. We'll move on to our next speaker now. So our next speaker, our next talk will be on cardiovascular health in pediatric chronic kidney disease children. It is my great pleasure to introduce our speaker, Dr. Saroj Patnaik. Dr. Patnaik is the head of department of professor and senior advisor in pediatrics and pediatric nephrology in Command Hospital, Air Force, Bangalore. He has served in pediatric nephrology across various armed forces hospitals for the past decade and a half, having established pediatric nephrology services in Command Hospital in Kolkata, Bangalore, and Army Hospital Research and Referrals. His research and areas of interest are in studying biomarkers in acute kidney injury, neonatal nephrology, and cardiovascular outcomes in renal diseases and nephrogenetics. He was the past secretary of ISPN. He is the editorial committee of the Asian Journal of Pediatric Nephrology and also serves as the National Webinar Coordinator and on the subspecialty board of pediatric nephrology. He's also the recipient of multiple awards, including the Om Satya Mehra Award, and is very well published with over 30 publications. We are very keen to hear from you today, Dr. Patnaik, and I'm over to you, sir.
Saroj sir, are you there around? Dr. Saroj? Dr. Saroj sir, you're there around? Saroj sir, can you please unmute yourself?
Hello.
Yes, we can hear you now.
Okay.
So you're over the phone, so can you please share your slides?
Yeah. So I'm already sharing my slide. It's showing us your screen sharing. So are my slides visible?
No, sir, only your name is visible on the screen.
Okay, I'll share the slides.
I was able to see the slides.
Is it?
Okay.
Yeah, now it is visible, yeah.
Okay, so thank you very much for this invite to speak on cardiovascular health and pediatric CKD. Over the next half an hour, I'll have a brief overview of the issues related to cardiovascular outcomes of chronic kidney disease. And especially in relation to the published data, there is a surfeit of data in the adult literature, but pediatric literature, the data related to cardiovascular outcomes in terms of the evidence base per se is limited. So when we talk of the cardiovascular health, I would like to stress upon that we are talking of an age-appropriate structure and function of not just the heart, but the entire vascular system, right from the microvasculature to the macrovasculature, and which is able to function well, not just at rest, but also during any kind of physical activity. And so there are two components, the structure, which is the pump, the conduit, and the perfusion. And all of these should be able to maintain the normal pressures and flow till the microvasculature for the perfusion of various nutrients and oxygenation. And the entire cardiovascular system and the cardiovascular health, right from the time of birth, keeps on undergoing dynamic changes. And there's a process of normal aging which happens. Atherosclerosis starts off very early in life, and yet the system is able to compensate it well for the degenerative changes which accrue especially after the second decade of life. So if we look at the published data, it's amply clear, and this is from the latest KDIGO guidelines 2024, and where we see that the mortality attributable to cardiovascular diseases is as high as 50% in the setting of CKD, as compared to a person whose renal function is normal, where the mortality may be just about 26%. Again, this is an adult data set. So overall, we have a multifaceted interplay of traditional and CKD specific risk factors, which I'll come to subsequently. And the entire process starts off with the onset of endothelial dysfunction, which finally culminates in structural changes. And in adult population, it leads across to very well-defined disease entities and syndromes. And along with the development of this cardiovascular disease entities, there is a progression of the chronic kidney disease, the various stages from stage 1 to stage 5. And as we reach the end stage renal disease, the overall morbidity associated with chronic kidney disease becomes very significant. So before we move on to the specifics of cardiovascular involvement, I think the concept of cardiorenal syndrome, which is coming into fore in recent times, needs to emphasize, especially in the children with CKD in stage 5 and beyond, where we have a combination of fluid overload, retention of sodium, along with inappropriateness of the excretion of the sodium and water load by the kidneys. And again, the kind of dialysis or renal replacement therapy being exhibited. So we have a combination of differences in the hydration status, which impacts ultimately the vasculature in terms of the pressure relationships at one end, and the inflammatory effects of sodium at another end. And all these ultimately lead across to combination of structural changes, inflammation, and endothelial dysfunction. And this cardiorenal syndrome has been classified into 5 different types. And if you look at as the cardiac involvement secondary to the renal involvement, then type 3 and 4 were entity of a cardiac dysfunction following AKI or chronic cardiovascular damage in patients with CKD, and that is what is the subject matter of our talk. But it is to be noted that there is a reciprocal relationship between heart involvement and the renal involvement, and the other types actually address these issues. So if we talk of the cardiovascular risk factors, what we know from adults, age per se is a independent risk factor for cardiovascular diseases because of the aging and the progressive atherogenesis which occurs in every one of us. And the traditional risk factors in terms of the body weights, hypertension, lipid levels, hyperglycemia, especially the adult populations where there is a significant prevalence of diabetes after a certain age, and related to diet as well as certain behavioral addictions, smoking, alcohol, all these things actually lead across to increased risk of cardiovascular disease. The fact to be remembered is, in addition to this, medication compliance does impact the way the progression of CKD occurs, as well as the impact of that on the function in the cardiovascular system. And adolescents perhaps mimic more of adults as far as the cardiovascular risk factors are concerned as compared to the younger age groups. hypertension, I will not dwell further onto this, but it's to be noted that there is a U-shaped association between systolic blood pressure and dialysis and all-cause mortality. And before a CKD patient actually moves on to stage 5D, actually there is a linear relationship between the systolic blood pressures and mortality in adult literature. Similar evidence in pediatric literature remains to be, it's lacking in terms of good longitudinal studies over a period of time. And when we move across to the modality of dialysis, again, the U-shaped association becomes important, that wherever the blood pressure plummets significantly during dialysis, intradialytic hypotension occurs, that itself becomes a risk factor for, again, damage to the cardiovascular system as well as the chronic kidney disease. Dyslipidemia, again, 50% of cases in dialysis patients which are attributable to cardiovascular disease, there is a combination of vessel calcification and dyslipidemia, and most, again, studies in adults show a prevalence ranging somewhere between 40 to 80% across the world. There is a difference between the kind of disease which is causing the chronic kidney disease, and it's well known that wherever there is significant proteinuria, the combination of proteinuria and dyslipidemia can have an additive effect, and the overall effect on the cardiovascular system as well as the progression of the chronic kidney disease, both of them can have an additive and more deleterious effect than being alone. Specifically, if you look at nephrotic syndrome has a insulin-resistant dyslipidemic state, and contrary to our usual thinking, where we know that steroid-resistant nephrotic syndrome patients have a combination of risk factors, so which does predispose them across to premature atherogenesis. But I think majority of the population of nephrotic children who have a frequent relapser or a steroid-dependent profile, this is one population which also has an additive effect related to the frequency of the episodes that the child is exposed across to. And we definitely need more data to actually look into this part. Not just a nephrotic range proteinuria, but any kind of significant albuminuria does increase the chances of a poor cardiovascular outcome as well as mortalities. And this is, again, from the latest KDIGO guidelines, where we can see that as the CKD stage increases and as the urine albumin creatinine ratio increases, the cardiovascular mortality in fact multiplies manifold, along with the other morbidities and other organ involvement. Here again, I would like to point out that in pediatric populations, we actually don't look in terms of arrhythmias as a primary presentation of most of the kids. Cardiac failure with CKD with fluid overload states, definitely we do see. But it's a bulk of subclinical cardiovascular involvement which needs to be looked upon in a very longitudinal sense for us to generate data as well as to have interventions. Now, the longitudinal course of dyslipidemia, once a dialysis has been started, that still remains a gap area. And it's well known that glomerular diseases do have higher baseline dyslipidemia. So is there a difference between the glomerular disease and the non-glomerular diseases in terms of dyslipidemia as well as the long-term cardiovascular outcomes? Needs long-term studies in that respect. What we really do not know is the longitudinal trajectory of lipid profiles, whether there is a role for fasting or non-fasting measurements in pediatrics. And again, a large number of these children, especially those children who would undergo a renal transplant, they would remain on immunosuppressants, and the impact of immunosuppression on lipid levels in the long term is something which again needs to be investigated further. And finally, the complex interplay of nutrition, inflammation, and proteinuria, along with the cytokine storms in the setting of chronic kidney disease, is an important factor which needs to be taken into account. And there is definitely an interplay of these, along with loss of albumin during the various dialytic modalities. And this also independently does impact the cardiovascular disease progression. So in this slide, we can easily we can see that there is a differential change between the glomerular etiologies versus the non-glomerular etiologies in relation to the presence or absence of dyslipidemia and the presence or absence of hypoalbuminemia. It seems that hypoalbuminemia with dyslipidemia has a greater impact than either alone. Similarly, urinary sodium levels and sodium to potassium ratios are associated with impaired kidney function. And so one of the targets for the therapeutic modalities for prevention of deterioration of the cardiovascular function has to look into this aspect. Now, there are a lot of drugs which do the CKD patients are hypertensive, and we use drugs for hypertension in them. The use of lipid-lowering therapies remains contentious. But what I would like to stress upon is ultimately the adherence does impact outcomes. And as we move away from a young child to adolescence, adherence factors become very, very important. And they do add on to the overall cardiovascular disease morbidity and mortality. Now, uremia is associated with various factors which have vasculopathic implications. So apart from the mineral bone disease, the calcium phosphate, PTH, and vitamin D pathways, inflammation, oxidative stress, uremic toxins, I would not get into the details of those, and homocysteine. The higher levels of these are well known to be associated with adverse cardiovascular outcomes, irrespective of presence of kidney disease. On the other hand, anemia, hypovitaminosis D, as well as again protein energy malnutrition in a subset of population across the world. The combination of this again would lead across to further damage than in the absence of it. So overall, uremia-related vasculopathy always remains in the background as the progression of CKD occurs from stage 2 onwards. So stage 4 onwards, when we are moving across to dialysis, there's an interplay of all these factors which impacts the overall chances of developing adverse cardiovascular outcome. So the overall, if you look at it, the master organ which determines the entire thing is the endothelium. And at whatever is happening at the level of the endothelial, at the level of the endothelium and the stabilization, it can impact the chances of thrombogenicity. The endothelium per se has to have a good balance in terms of reactivity of vasoconstriction and vasodilatation. And below the endothelium, these vascular smooth muscle cells, they are important for the structure of the vessels and the overall responsiveness and the stiffness of the vasculature. So it is well known calcium and phosphate product, they do impact the propensity for calcification in the vasculature. FGF23 is one factor which is elevated in CKD, but apart from the effect through the mineral bone disease, there is a direct toxicity on the myocytes, and higher levels of FGF23 again are associated with left ventricular hypertrophy and increased mortality in adults. But when we look at the pediatric literature, the role of FGF23 in arterial calcifications does remain contentious. The role of intradialytic hypotension and myocardial stunning and impaired cardiac function I have alluded to earlier. Oxidative stress, the important point is a plethora of molecules would be exposed to stress because of removal of antioxidant during dialysis at one end. At the same time, with a poor renal function and endothelial dysfunction occurring, accumulation of oxidation products with the progression of CKD does occur. And with this, especially the oxidized lipoproteins, albumin, and parathyroid hormone, these three factors again contribute to the vasculopathy. And overall, this endothelial dysfunction associated with pro-inflammatory, pro-atherogenic state, along with the poorly controlled anemia, either initiates or progresses the cardiovascular involvement in the setting of CKD. Now, the vascular calcification, there is ample data from autopsy studies as well as from data from adult studies, especially involving documentation of coronary artery calcium by computed CT studies. And it does show that there is a clear-cut relationship between the decline in the renal function and the vascular calcification. Now, the ethics of looking out for vascular calcification in the pediatric age group, especially in a longitudinal sense, again becomes limiting. But we can easily extrapolate the data from the adult population. And here I would like to point out one thing, that in a setting of atherogenesis, the main problem lies at the level of the intima level and these subintimal musculature. And whatever calcification, if it occurs in the setting of it's an intimal calcification which primarily occurs. So in an adult with a coronary artery disease, there is a gradual luminal occlusion and symptoms start off. While in case of a pediatric setting, especially in the setting of CKD, the calcification is occurring abluminally in the tunica media layer. And hence, as far as the traditional approach to look at the cardiac involvement in terms of, say, for example, angiography, there is not going to be any kind of change in the luminal diameters, but we have to look out for the functional aspect of the vasculature. And hence, in case of CKD, there is a difference between the level and the vessel involvement. So if you have a combination of CKD and atherosclerosis, now there is a double whammy where there is a subintimal calcification as well as a medial calcification. And this, as the stage of CKD increases further, and this leads to much more poorer outcomes in the higher grades of CKD as compared to the earlier stages of CKD. Variety of mediators are involved in this. But what is to be remembered is, actually there is a transformation of the vascular smooth muscle cell from a muscle cell phenotype to a osteochondrocyte phenotype. And this osteochondrocyte phenotype is actually stiffer, and along with this also leads across to a vicious cycle where there is more and more calcium deposition which occurs. Now, there are in the body calcification inhibitors, and in settings of CKD, the calcification inhibitors gradually go down, while there is an upregulation of the promineralization factors, and this adds on to the overall calcification in the vascular smooth muscles and stiffening of the arteries. Now, in recent times, it has been recognized that the entire process is not only related across to intracellular deposition of minerals, but there are involvement of extracellular vesicles, and probably there is an epigenetic regulation involving microRNAs. And so in advanced CKD, especially with people who are on hemodialysis, there is a phenotype of increased endothelial release because the endothelium is not normal, is dysfunctional, and the extracellular vesicles which have the microRNAs, they are also dysregulated, and there is a impaired angiogenesis and a compensatory response in these patients. So this, interestingly, when we look at this extracellular vesicles, we can actually detect endothelial microparticles. Now, if you look at the endothelial microparticle counts and the extravesicular the microparticles, interestingly, if you look at the structures as well as the composition, it is not uniform across from a patient who is in a from a normal individual in a pre-dialytic state and at various stages of CKD and at various modalities of the renal replacement therapies. So there are differences between these various subcategories, and this may also be a factor which is related across to the kind of cardiovascular outcomes which we see in these populations. So if you see out here, you can see the patients with a renal transplant versus patients on, say, on peritoneal dialysis or hemodialysis. Again, the composition of the extracellular vesicles and the microRNAs are not necessarily the same. And depending on the stage, there are changes which are noted. Various other molecules have been studied as markers of cardiovascular risk factors. But I think just like other disease processes, the number of such biomarkers will keep on increasing. But what matters finally is that for us to recognize that there is an endothelial dysfunction associated with inflammation and which leads across to vasculopathy. Along with this, uremic toxins and albuminuria which lead across to a disruption of the nitric oxide synthesis function and the balance with the endothelial pathways, finally lead across to a perpetuation of this endothelial dysfunction and atherogenesis. And along with the other mineral-borne disease factors, vascular calcification sets in. And so there are structural changes which impact the coronaries, which become symptomatic in a little older age group. But the changes in the vessel itself lead across to differences in the pressure resistance mechanisms. And as a compensatory mechanism, the heart has to compensate there, and left ventricular hypertrophy, the diastolic dysfunction followed by systolic dysfunction. And if it is not corrected, in a long-standing state of fibrosis sets in. And this entire process has underlying epigenetic mediators, probably through a set of microRNAs. Now, the time spent on dialysis, there is a very strong linear association between time on dialysis and vasculopathy and progression of calcification. Again, depending on the modality of dialysis, the duration of the urea milieu exposure, and again, the presence of the balance between the inflammatory and the pro-calcific factors, especially the kind of therapies which we use in treating CKD, they do impact the overall propensity of vascular calcification. Now, in the pre-dialysis state, the calcium accumulation occurs. It does occur, but there are calcification inhibitors which are still there. So still stage 3 or 4, we are still protected to a reasonable extent. But from stage 4 onwards, and especially once goes into stage 5D onwards, there is definitely a time-dependent accumulation of this calcium load in the vessels, and apoptotic processes, cell death, and they occur across with loss of bone mineral density. And hence, we have this calcification paradox where you have loss of bone mineral at one end, but a deposition of calcium in the extraskeletal system. And this is related across to a loss of the bone buffer mechanisms. Now, not only the coronary, but the vasculature across the entire body has a progressive calcification which occurs, and which we can detect by, again, CT scans. But in pediatric population, again, there are limitations. Now, arterial stiffness assessment by looking at the pulse wave velocity gives us a good non-invasive way of looking at the risk of cardiovascular disease. And it's as shown out here, the odds of developing cardiovascular mortality jumps up more than 6 times. And the chances of incident heart failure becomes more than 3 times in the setting of increased pulse wave velocities when we progress across from CKD, low stage of CKD towards ESRD. So overall, this is the multiple number of factors which play. And here, one of the factors which also comes into play is the intestinal dysbiosis, which happens in setting of CKD. And this is again an understudied topic in our pediatric population. So we have chronic kidney disease at one end, which leads across to arterial disease, a second associated with the cardiac disease. And there are changes occurring at the level of the microvasculature. And when we put a patient onto dialysis, there are factors associated with the dialysis itself, which are which again kind of impact the overall risk, cardiovascular risk, as well as the calcification mechanisms. Now, so if you see out here, the factors which are associated with cardiovascular disease versus vascular calcification, most of them are common with each other. Elevation of homocysteine is more specific towards cardiovascular disease. So overall, how do these clinically manifest? What is to be remembered is, undoubtedly, there are elevated risks for cardiovascular disease, and undoubtedly, it remains underdiagnosed or under-recognized in the pediatric age group. While an adult does manifest with a coronary artery disease or a heart failure or arrhythmia or vascular stenosis, the vascular calcification keeps on worsening with declining renal failure, renal functions, and it does predict the adverse cardiovascular outcomes differently. If you look at the symptom complexes of this, there are overlapping symptoms. Swelling and dyspnea can be associated with the various manifestations of CKD as well as various cardiac illnesses. So the recognition of these entities as a clinical entities is also very often missed in the adult population. In pediatric population, it becomes clinically even more foxing. So the endpoints, if you see in adults, there is a luminal restriction, heart failure and arrhythmia, and we do get clinical markers of cardiovascular disease, and the angiography is a good modality for them to pick it up. While in case of pediatrics, the symptoms are rare, the pathology is abluminal, and yet we have subclinical markers, especially imaging-based markers, which have been very well demonstrated to be associated with, which are predictive of future adverse cardiovascular events in adults. So imaging provides us a good modality in a clinical setting, especially a point of care setting, for looking at and assessing the cardiovascular risk in a patient with CKD. Variety of biomarkers which are available, but a single biomarker which can predict CKD as far as the pediatric population is concerned still remains to be defined. Now, it is well known that the carotid intima media thickness and the pulse wave velocity, they do start increasing even before the first decade of life is completed. And between the CKD stage 2 to 4 in the CKD study, it has been found that there are pulse wave velocity, arterial stiffness changes, CIMT changes, or LVA changes do occur in at least 1 in 5 such kids between the 4C and the CKD studies. In pre-dialysis settings of adult CKD, again, the data is very robust out here, where it is seen that the prevalence of cardiovascular disease, again, depending on the cohorts, changes. But what is to be noted is majority of these people are hypertensive. At least 1/3 of them have had some kind of ischemic event, which perhaps we will not see in a pediatric age group. And despite caring by adult nephrologists, worsening of symptoms occurs in at least 1 out of 5 of them. So if we look at the pediatric population as whole, the number of children under care of pediatric nephrologist is actually limited. So a large number of such children with a subclinical manifestation of this, they do get missed. Hence, a child who gets diagnosed as CKD needs to be under care of a pediatric nephrology right from the beginning, even in the earlier stages of CKD. And with cardiovascular disease, there is going to be a add-on decline of the renal function test. And even after initiation of RRT, this factor will carry on. And this is again very clearly brought out in the adult data, where even before initiation of the dialysis occurred, the overall chances of developing a cardiovascular event was very, very high. The slope of such a thing would be much lesser in case of pediatric age group, but definitely if we use the right kind of subclinical markers, we would also be able to define it in pediatric age group. Now, if you look at the risk of death from cardiovascular disease versus the risk of progression to the stage 5D CKD, it's interesting to see that the risk of death actually exceeds the risk of progression to ESRD in the long run in the adult populations. Similar data sets for pediatric populations would be worth looking into, especially with the long-term cohorts which have been created with CKD and the C4 studies. Now, again, the prevention of progression of CKD has implications of CVD. It is again amply brought out from the adult data sets. We can see that when you move away from CKD stage 1 to CKD stage 5, the cardiovascular disease risk jumps at least 5 to 13-fold. And here, albuminuria and decline in the eGFR are important determinants. Similarly, again, with onset of dialysis, again, cardiovascular disease is going to be a factor. And especially in the initial 2 to 3 months after initiation of dialysis, that is one critical period where the number of adverse cardiovascular events can occur. And this is one time period when one needs to watch the children more carefully. Now, when we look at the transition from CKD to the stage 5D or ESRD, definitely there has been an increase in the cardiovascular disease in the months prior to this, as I brought out earlier. The overall data on this is very limited when you look at clinical cardiovascular disease in pediatric age group or even adult age groups. When we look at precipitation of heart failure per se, again, the rates of atherosclerotic cardiovascular diseases and heart failure, they seem to be comparable across. But when we move towards the higher stages of the CKD and on dialysis, apart from the cardiac involvement, the cerebrovascular involvement, peripheral vascular disease becomes significant. However, the risk factors for this again needs to be defined properly. Now, in pediatric population, we cannot take away the long-term impact of nutrition and BMI, the physical activity in the pediatric age group, and a genetic metabolic predisposition, especially in case of familial settings. So these three inflammatory disease processes are well recognized today in the various guidelines as the atherogenic and needing specific interventions. But what we need to remember is there are a lot of iatrogenic factors which we give across during the course of our therapy. So overall in pediatric age group, for me, the dysregulated mineral metabolism and blood pressure probably are more important than other factors. And thankfully, these are factors which are amenable to modification. Now, before 21 years of age, again, the rates of cardiovascular disease as a cause of all deaths, again, these are enlisted out here. But it's interesting to note that even if you start on dialysis, about 20 years, your survival actually is less in an individual, and 1 in 5 children with CKD will develop cardiovascular diseases. And if you look at the ERA registry data, the primary glomerular diseases in Europe, again, we see that at least 34% of the deaths are attributable to cardiovascular diseases. Now, subclinical cardiovascular disease, again, imaging tools are available where specifically we have to look at the cardiac function. But again, for the pediatric age group, the left ventricular structure and function, the left ventricular hypertrophy and left ventricular mass index are known to be indices associated with worsening cardiovascular outcome. But again, there is a need for greater data in pediatric age group. I think it is important to understand that the initial left ventricular hypertrophy is an adaptive response. But as the left ventricular hypertrophy persists, then it will lead across to permanent changes, and the outcomes are going to be worse with the presence of left ventricular hypertrophy. Now, the dialysis modality does impact the overall cardiovascular outcomes, and observational studies seem to suggest that there is a difference between hemodialysis, peritoneal dialysis versus not starting dialysis. But in terms of trial, especially the ideal trial, did not show any kind of a great difference whether you initiated dialysis early or late enough. As far as the pediatric data is concerned, again, trials to that effect, I am not aware of, which have shown such kind of a difference. So this again shows the various indices of the cardiac function. Now we look at the CIMT with chronic kidney disease. These are it's well known now that CIMT does increase with the progression of CKD and is a good subclinical marker of cardiovascular diseases. Now from in the 4C study, it is interesting to note that about 2/3 of the cases were actually related to Kakut, and about 40% of them had elevated CIMT and 20% of them had pulse wave velocity abnormalities. Even in the baseline data of this, there were significant subclinical markers suggestive of cardiovascular dysfunction. Now, the progression of hypertension and LVH between CKD 3 to 5 is very clearly brought out in the analysis of the data sets out here. So currently we have progression data sets till about 8 years of age, and they do clearly show a progression, and systolic blood pressure is one of the major factors associated with the progression with a greater risk of cardiovascular adverse outcomes. There may be factors related to the ethnicity as well as the gender. The current data set seem to suggest that. Now, adults have a cardiovascular disease scoring system. Unfortunately, we do not have a pediatric system, and we would need to look at it. Hello. Now, last few slides on how to reduce the burden of cardiovascular disease in children. The KDIGO guidelines have put across a variety of interventions which can be there for arresting the progression of cardiovascular adverse outcomes in the setting of CKD. Out of this, if we see the ones which are marked as indicated as heart, they are specific to the cardiovascular component, but majority of them are actually not really available for the pediatric population. So these are the variety of interventions which are recommended for adults. A number of them would be useful in the pediatric age group, especially for adolescents. Smoking in adolescents is something which we can focus upon. Now, there is a lot of stress on anti-lipidemic therapies and other pharmacological therapies, which again are not applicable to pediatric age group except for the RAS blockade. So to reducing the burden of CVD in pediatric CKD, I think the focus on avoidance of sedentary status and looking at the BMI is the most important part. Preemptive transplant can reduce the exposure of the child to a period of dialysis and the attendant negative consequences of it. The evidence of the bone mineral metabolic disease and vascular calcification is good, but with the cardiovascular disease events, that still remains lacking. And a different approach to the dialysis with more intensive dialysis programs and focus on hemodiafiltration. There seems to be data which suggests that there is a lowering of the cardiovascular risk factor. Now, if we look at the dietary approaches recommended for adults, there is a Mediterranean style diet. But important thing is in pediatric age group, we should not be restricting the protein. There is definitely a role for BP monitoring, especially the ambulatory blood pressure monitoring, and as well as remaining physically active. At least 60 minutes of daily activity are recommended for kids. The calcium intake recommendations should be age appropriate rather than the cutoff which is there in adults. And the role of calcium free versus calcium based binders, a strong evidence for preferring one of them in pediatric data sets is lacking at this point of time. Similarly, that is true also for the vitamin D levels. Definitely, there is a role for control of arterial hypertension and left ventricular hypertrophy by looking closely at the blood pressures and a tight control of it. In adult populations, again, there is clear data which shows that the lowering of the dyslipidemic states, lowering of LDL has positive benefits for cardiovascular disease. But in once a dialysis has been started, the effects are not really very clear. For pediatric population, again, this has to be looked in with more longitudinal studies. Definitely focus on the BMI. This is from the latest from the global burden of obesity data sets, and it seems very clearly that the obesity pandemic in the world is going to increase, and obesity associated nephropathy and adverse consequences would be more encountered by pediatric nephrologists. Role of drugs, I think it is still experimental, and there are data which seems to suggest that there may be some benefit, but today we cannot recommend at this point of time. And proactive risk evaluation and screening is probably the only thing at this point of time we can do very systematically. Address albuminuria and optimize our approach to bone metabolic diseases. In terms of echocardiography, speckle tracking echocardiography would be a good modality in the future, and CMT assessment is important out there. Now, better dialysis strategies, the HDF heart and height 3H study seems to again attest the fact that hemodiafiltration has better benefits as compared to the conventional hemodialysis strategies. Now, we may think that preemptive transplant is good and it may reduce the cardiovascular make the cardiovascular outcomes better, but it is to be remembered that there is an additional effect of immunosuppression, and there is an effect of the overall the immunosuppression, as well as whether the effect it goes on to the lipid levels which the person has been exposed to, as well as the blood pressure after transplant. Unless they are addressed across, the outcomes may not necessarily be great. It clearly shows that there are extracellular DNA in the blood and which are pro-inflammatory, which kind of the innate immune system is activated by them. And surprisingly, the people with transplant seem to have the highest level of this extracellular DNA. So this is one population which we still need to look out in the long run in terms of the cardiovascular outcomes. The sheer number of pediatric transplants is much lesser than adult populations, and longitudinal studies in the long run are needed for this. So overall, more pediatric studies are needed for post-heart renal transplant population. And this extracellular DNA may have a pathophysiological role in modulating the endothelial function as well as the arterial stiffness. So to summarize, overall, we know that there is a elevated vulnerability to cardiovascular events in more than half of patients with CKD. Predominant cause of death in CKD stage 4 and beyond is cardiovascular, which contrasts with the persons with a normal kidney function. It's at least twice of that. CKD per se is an independent risk factor for cardiovascular disease because of a dysregulated mineral balance and uremic toxins. Albuminuria and the eGFR decline are separate indicators. And as they decline, as they increase, the risk actually multiplies further in a very non-linear exponential fashion. And there are shared risk factors between cardiovascular disease and CKD, and we need to dissect them out across the various age groups. And we definitely need more longitudinal pediatric studies on epidemiology and trials in relation to the therapies for prevention of this. Thank you very much.
Thank you, Dr. Saroj. That was a very informative and comprehensive talk. We have a few questions. What are the earliest signs of cardiovascular involvement in children with CKD, you think? The earliest sign?
I think for a kid with this would be worsening of blood pressures. If you are monitoring serially the blood pressures, if the blood pressure are rising, we do not look at, pulse wave velocity determination. If you are doing serially, you would be able to pick it up. But in a clinical setting, a good clinical examination on the bedside for the feel of the pulse itself. I think most of us have moved away from there. But that's one. The other good cardiac examination for, again, cardiac chamber enlargement. Initially, the hypertrophy may be concentric, but subsequently it will increase. And so as far as one of the first signs, I would say a good clinical examination, but more than that, we would need to look at the subclinical markers, at least by ultrasound on the bedside and a 2D echocardiography on a repetitive basis. A worsening of the overall renal function associated with edema per se, or persistence of edema. But I think by the time we have already reached a late stage. And patients who are undergoing dialysis, the intradialytic weight gains and the blood pressure profile during dialysis, I think that's also gives you a good indicator as to the progression of the cardiovascular status of a child.
Okay. And the use of pulse wave velocity and CIMT, would you do that clinically? And if so, how often?
I think there are no specific guidelines to that effect, but probably it would be good to do them at least once a year.
Okay.
The issues are related to lack of normative data sets, reference intervals, and these reference intervals need to be ethnicity dependent, because the same Caucasian population, the CIMT levels versus Indian population, because the predispositions are different, and we need to have normative data sets out there. And that's sorely lacking in pediatric age group. Whatever normative data sets which are there are based on a very limited population subset. So at least once a year, we need to look at it. The other part is normalization of whatever parameters which we have in relation to whether we interpreted the absolute values with the reference population, or we normalize it in relation to the BMI, for example. So the SDS scores for that. That's one more question which needs to be answered across.
Okay. We've got a very interesting question in the chat. Often adolescent children want to know whether weightlifting in the gym is recommended for children with CKD. What would you think of that?
I would suggest that as long as the child is able to do that and the blood pressure are under control, why shouldn't he undergo? And in fact, the physical activity which is recommended, you have a combination of resistance training as well as cardio. So If this is a little bit of resistance training, fair enough. But if the child wants to just keep on doing weightlifting without looking at the overall activity, that's something which we need to look in. I would look at the blood pressure of the child first, the control, and then because those episodes of weightlifting may expose the child, the vasculature, to a severe rise of blood pressures, and it may not be acceptable for us.
Thank you so much, Dr. Saroj, for your time and for the talk. We'll now I'll give it back to Dr. Kalavani. We're going to go through the polling, I think.
Thank you so much, Patnaik sir. Thank you, Flynn sir. Like, I think he is already left for from the meet. Thank you so much, Saroj sir. Now, I think we are already late. We will move on to the polling sessions for the trainees. This is next webinar would be the last webinar, and next webinar will not be having the polling session. Instead, we'll have the winners announcement in the next webinar. And so we are finishing the webinar on May 3rd, which should be for this year. And probably next year, we will have a different interesting theme for the following year. Thank you so much, Dr. Sharon, for joining with us. Like, if you're interested, you can stay back for the polling session. Otherwise, you're good to leave. Not an issue. Amrish, you wanted to tell something?
No, thank you, Dr. Sharon, and thank you, Dr. Patnaik. These were excellent session, and we can go ahead with the polling session. Thank you, Dr. Kalavani.
Thank you. Can we go ahead with the polling session? Last 1 minute for the poll. I think we can close the polls. Oh. Can we end this session? Dr. Amrish, Dr. Sharon, Saroj, sir?
Yes,
Yeah.
please go ahead.
Yes, ma'am.
Thank you so
Thank you
much,
very much.
Dr. Sharon.
Thank you all.
Thank you.
Thank you so much. Bye-bye.
Bye-bye, sir.